Okay, now we're going to talk about some specific examples of problems with red blood cells. All right. Tell me how the body responds when you have problems with red blood cells. What does the body do if I have too few red blood cells? We've already kind of talked about it. What happens? We increase our respiratory rate. We increase our heart rate. And our blood pressure my blood pressure will hold okay for a while, and then it'll start to drop, right? Because what have I got an issue with? If I don't have enough red blood cells, I have an issue with volume and oxygenation. Those are our two problems here, okay? So we increase the heart rate and the respiratory rate to circulate those existing red blood cells. The blood is redistributed away from the skin, the GI tract, and kidneys. Where is it shunted to? The heart and the brain. Okay. And then the kidneys will throw out the erythropoietin to cause the bone marrow to kick in and start increasing the production of red blood cells. So our goal here is to try to ward off any tissue damage or hypoxia so that we don't have blood being shunted away. Okay? So when we have too few red blood cells, we call that anemia. And when we have too many red blood cells, we call that polycythemia. Okay. So let's talk about when we have too many. When we have too many red blood cells, that is called polycythemia. And polycythemia vera is a malignant cancerous condition where you have too many red blood cells. But you also have too many leukocytes and too many platelets. So you have what we call well, God, the word just went out of my mouth. You got too much of everything. Let's just break it down. Okay? So you have an overproduction. So what do you think your hemoglobin level is? Your hemoglobin level will be high. Your hematocrit will be high. Platelets, WBCs, high. Symptoms, what happens when you have so many cells out there is that the blood actually becomes thicker. It's very viscous. So thick blood does not flow as easily as thin blood, okay, or normal blood. So the blood can circulate in those tiny arterioles and capillaries and things like that. So it is an oxygenation issue. You can't get the oxygen to those tissues. So symptoms, they have headache, they have dizziness, ringing in the ears, they may have blurred vision. These patients usually have a very reddish complexion. They look flushed. They may have itching. Usually their blood pressure is high because they're trying to pump that viscous blood around. So the blood pressure is high. So what do I have a risk of? A big, huge risk of? Clots. I've got thick blood moving slow, I have a risk for clots and thrombosis. So these folks have very poor tissue oxygenation and can get into very severe hypoxia. So what our treatment is, before we go in there and we start pulling off units of blood, which is what this says, have a unit of blood phlebotomized or taken off to keep the hematocrit normal. That means you do a venipuncture and your patient donates a unit of blood 2 to 5 times a week to get that level down. Okay? But just think about what's going on here. What else do you think is going to be ordered for these patients? We want to get these people fluids. We got to get them hydrated. Got to thin out that blood some, okay? Oxygen. What else? And anticoagulants. Amen, sister. Absolutely. Good Lord, you guys are thinking. I love it. Okay, so this is what you're going to be doing while somebody's getting ready to pull blood off. Okay, let's get their IV going. Let's get fluids going. Let's get pulse ox going. Let's get their oxygen moving. Let's give them some heparin. Yes, it is. Cancer of the bone marrow, yes. This blood is not going to be used. No, this blood is not going to be used and put in somebody else. No, because it's too thick. This is damaged, so we're pulling it out. So they have a lot of cells, but the cells that they have are usually abnormal. There'll be some normal ones in there, but they're being put out so fast that they're not normal looking and normal functioning cells. Okay. Okay. This is a picture of a person having blood pulled out, and it's just like when you donate blood. Okay. So polycythemia vera is that they have too many cells in their blood. The blood is thick. Your patient has severe hypoxia. And we've got to get that blood thinned, reduced, and get your patient oxygenated. Good. Okay? Now, when we're talking about anemia, anemia is the reduction in either the number of red blood cells, a reduction in the hemoglobin, or a reduction in the hematocrit. Anemia is a clinical sign. It is not a diagnosis. Okay? If your patient is diagnosed with anemia, there's a reason. There's some other reason that they have this going on. It may come from dietary problems, genetic problems, bone marrow disease, or excessive blood loss or bleeding. And this is usually GI in nature. That is one of your more common causes of anemia, is a GI bleed. And how did we say, do you remember when we talked about NG tubes and GI bleeding and irrigation and all that business? Remember all that? Bring it back, okay? Because you know, anemia, like I said, happens for different reasons. So you may have a patient in the hospital, they've had a really bad GI bleed, they're anemic, You've put an NG tube in, you've got an IV going, you have to give them packed cells, you may have to give them plasma. And you're monitoring all that business, plus their NG output. All that business. So when we're talking about types of anemia, one of them we need to talk about is aplastic anemia. This is where you have a complete failure of the bone marrow. So on the opposite end of the spectrum from polycythemia, this one you have low red blood cells, low leukocytes, and low platelets. And usually when you have low something, what's the suffix at the end of that word? Penia. So thrombocytopenia means you have low platelets. Leukopenia means you have low white blood cells. Bless you. Okay? So in this case, you have what's called a pancytopenia. That means everything's low. So causes, it can come from drugs, exposure to toxic chemicals or radiation. Drugs such as streptomycin and chloramphenicol can cause bone marrow suppression or bone marrow failure. But sometimes, in about 50% of the cases, you don't know why. You cannot ID a cause. The onset may be rapid or it may be a slow progression. But either way, you have extremely low blood cell counts. So what we see with our patients, they are very pale, extremely fatigued, they're short of breath, tachycardic, tachypneic. Remember, they have low red blood cells. They're going to have those signs and symptoms. Okay? They have low white cells, so they're going to have frequent infections. They have low platelets. They're going to have problems stopping bleeding. Got it? Oh, no. Okay. Do what? You don't type as fast as I talk? So just think about it. Rather than writing every word down, you got low everything. Low everything, right? Y'all just kill me taking pictures of the screen. That fascinates me. No, I'm fine with that. The first time I saw that, I was like, no, it just fascinates me that y'all do that. That's just, I would never have thought of that. Y'all are tech savvy. That's fine. However you get it, doesn't matter to me. Okay, so everything's low. We're going to have risk of bleeding. We're going to have risk for infection, and then we're going to have problems with our oxygenation. Okay, so what do we do about it? We need to give these folks blood. Okay, transfusions to replace their red cells and their platelets. We're going to treat any infections that they have, giving them some antibiotics. We may be giving them steroids, corticosteroids. Now, we're going to try to see if we can get, we're going to be careful about just a whole bunch of repeated transfusions. So we're going to consider if once these levels drop to life-threatening, we're definitely going to transfuse. But repeated transfusions increase the chances of your patient starting to have reactions to the blood that you're giving. Okay. And it also shortens the lifespan of those transfused cells. That's why we just don't give blood all the time. Our preferred method of treating aplastic anemia is stem cell transplants, and you're going to hear a whole lot more about that in 202. But remember, what are stem cells? Cells that don't know what they're going to be yet. So if we put in stem cells and we start to put out the epigen and the other one for platelets, it kicks those in. Hopefully, it kicks those in to where more of those are produced. So that's our preferred level. But if my hemoglobin is 5, you can't wait for that. You got to give me some blood. All right. So that's look at your patient. Look at your patient. And again, it's not your call. It's not your call. But just know that that's going to be what we're kind of working toward if the bone marrow has completely stopped working. If the bone marrow does not recover, then we're going to look at bone marrow transplant if we can find a donor. And they'll talk more about bone marrow transplants in 202 as well. Okay. But that's kind of that's a transfusion. Your patient may need immunosuppressive therapy if autoimmune is the reason that they're having this problem, or they may need a splenectomy if the spleen is destroying what red blood cells you have. So it just depends on the cause. There's that it depends again. But these are some options. Okay, so when we're talking about autoimmune hemolytic anemia, this is where something in the body is attacking the cells that are produced. So the bone marrow is still making those cells, but they're being destroyed once they're released into circulation. Something in the body is attacking them. It's seeing it as an antigen, and it's attacking it and killing it. Causes may be certain infections, certain autoimmune conditions like lupus. It may be a virus. It may be a drug reaction, or certain cancers like lymphoma or leukemia, which are directly coming from the bone marrow. Okay. Have you heard about hemolytic anemia of the newborn this semester? What is that? RH incompatibility. Right. If mom's negative and the baby's positive, you can have that hemolytic reaction there. And then sometimes transfusions can cause that. Remember, we talked about it was the second type of reaction. Oh, Lord. It wasn't the ABO. It was the ABO incompatibility and then the next one. Huh? Anaphylaxis, thank you. Yeah. Anaphylaxis, where the antigens and the antibodies are kicking in. And also, your body could react to the leukocytes. Remember, we talked about that too. The body can react to the leukocytes that's in the donated blood. And you can have that type of reaction as well. But you get into a hemolysis of your cells, it breaks them down, and then your patient gets the anemia as a result of that. Okay? So what do we see in these folks? Remember, these folks are having blood cells destroyed. It's not that they don't have them, it's that they're being destroyed. So then we start to see the yellowing, the jaundiced appearance. Okay? They're pale, fatigue. Again, you got that tachycardia, shortness of breath, and hypotension. Okay? But these folks may look jaundiced from the breakdown of all these cells. And you see it in the sclera, and you see it in their skin. Yes? Pathological. Physiological. It's not liver damage. It's not liver damage. Okay, so your patients appear jaundiced. They have high bilirubin levels from all these red blood cells that are being broken down. And then they have a positive Coombs antiglobulin blood test. Do you remember Coombs and direct Coombs and non-direct Coombs from 106? Did they go over that? Okay. What does Coombs tell you? It detects those antibodies that are working against red blood cells. So what we do is we give these folks blood transfusions, but we need to ID the cause. ID and try to treat the cause. But we're probably going to need to replace those lost red blood cells. Steroids, we may be giving those. And your patient usually recovers from this. It takes them a little while because remember, their blood levels are low. There's been a war inside their body, so they got to get over that. So it takes them a few days to a few weeks. They may need a splenectomy if the spleen is overacting, and then they may need chemo. Why do you think chemo? Exactly. Chemo will wipe out all the bone marrow, and then hopefully it picks back up working like it's supposed to. Good. Good. So aplastic is the bone marrow has stopped working. The hemolytic anemia is the bone marrow is working, but something in the body is attacking those cells. Okay? But it's still anemia. Did you notice the signs and symptoms? You still got the same signs and symptoms. With hemolytic, the jaundice starts rolling in. Okay? But you still got tachycardia, increased respiratory rate, blood pressure dropping. Okay, still got those same problems going on there. Now, iron deficiency anemia is not an issue with the bone marrow, it's an issue with the iron content that's in the body. We have either decreased iron intake or the iron is not being absorbed appropriately. This is one of those malabsorption kind of things. This is your most common type of anemia. And you see it more often in women, older adults, and those folks who just have poor eating habits. Remember we talked about you need iron in order to produce red blood cells and have the heme part of hemoglobin so you can carry oxygen. And you may see iron deficiency anemia either in from blood loss or from, like I said, just the decreased GI absorption of iron. So here are your symptoms. The main ones is your patient is fatigued and your patient is pale. And you'll see patients that'll come to you and that's their complaint, is I just have no energy whatsoever. I almost don't want to get out of bed in the morning. I don't even want to get my clothes on. And you check their blood and their CBC shows a hemoglobin of 8. So then you got to start asking yourself what is going on here, and then you start doing your history, start doing your assessment, and find out what's, maybe they're not eating. Maybe they've been on a diet for 2 weeks and they just have not eat. Okay. So we need to assess for a GI bleed. In very severe cases, they will have orthostatic changes to their blood pressure. And what you'll see on their CBC is low RBCs, low hemoglobin, low hematocrit, low serum iron levels, low ferritin levels, and a high total iron binding capacity. Just know it's low. Their iron levels are low, and then their hemoglobin hematocrit will be low as well. Okay, so what do? We give them iron if we need to. We try dietetic changes first, encouraging foods that are very high in iron. These are like your red meats, your organ meats. Egg yolks are very high in iron. Kidney beans, leafy green vegetables, and raisins. Basically, you need about 10 to 15 milligrams of iron every day. And you may need even more than that if you are, pregnant. Remember, they stick those people on iron immediately, right? Or if it's a female and it's she's losing a lot of blood through menstrual cycles, they may need to have supplemental iron. 10 to 15. So if your patient is put on iron supplements like ferrous sulfate, which is a PO iron supplement, I want these people to take between meals. Helps with the absorption. Any kind of iron that they take that is a liquid is bad to stain the teeth. Okay, so we need to make sure that our patients are instructed to take that with a straw and need to do good mouth care afterwards. Okay, brush their teeth. It'll stain their teeth. Iron may also be given as an IM injection. What's important about IM iron? How does our technique change? We use that Z-track procedure. Are you aware of what I'm talking about? Okay, good. So Z-track for IM injections of iron. In the hospital, you may give iron once a day in an IV piggyback. And again, make sure you've got a good patent IV, because when that infiltrates, that stains the skin, under the skin, and it don't go away. Okay. So you may be giving it PO, IV, or IM. So your hemoglobin is going to go up. It should go up a couple of grams in about 4 weeks. It's not an immediate fix. Okay. But if it's too low, that we may have to really up our dosages of iron that we're giving our patient. Another malabsorption one that you may see is pernicious anemia. This is when you have a vitamin B12 deficiency. B12 is what we need. We need it for red blood cell production, and we also need it for good nerve function. So the reason that we have B12 deficiency, it may be because we have a poor intake of that vitamin. Vegetarians may have this because of their diet, or a diet that is lacking in dairy products. So either they're not taking enough of it in, or they have an issue with the absorption of vitamin B12. Remember, you have to have that intrinsic factor for B12 to be absorbed. And that intrinsic factor comes from the gastric mucosa. So if you've had removal of the stomach, you don't have any gastric mucosa anymore. So you cannot absorb vitamin B12. So we have to give it to you in other ways. If you've had, let's see, gastrectomy, a small bowel resection, chronic diarrhea, diverticula, any of those things can affect the absorption of B12. So what do you see? The primary, well, one thing that makes this a little different from the other ones is that your patient will have a smooth, red, sore tongue. It's a really red, they call it beefy red, sore tongue. And then because you need B12 for nerves, you start to have numbness and tingling in the hands and feet. That makes this one a little bit different. Do I still have pallor and some tachycardia and some shortness of breath? Yes, I can, because it is anemia and I have decreased red blood cells. Okay, but these are some extra little things that have been invited to the party because of our B12 deficiency. It may be mild or severe, but this usually develops slowly. Treatment for this is increasing the intake of B12, animal proteins, eggs, and dairy. But again, if it's because of the malabsorption, we may have to be giving intramuscular injections of vitamin B12 every month. And this is for their lifetime. You don't suddenly grow back gastric mucosa. Okay. I know. Hang in there. Hang in there. Questions about those? So the two malabsorption ones have to do with iron and vitamin B12. The bone marrow ones are what? Aplastic and autoimmune hemolytic. And then what's the one when you just have too much of everything? Polycythemia. Good. Okay. Good. All right. Well, let's talk about sickle cell. Have y'all covered sickle cell in peds? Did you cover it thoroughly? No. Okay. We'll talk about it thoroughly today then, okay? All right. Well, that's good. Case studies are good. Lecture is better. Okay. All right, well, let's talk sickle cell then. What happens with sickle cell, as you've learned from your case study and your reading? It does. It affects black people. Absolutely. It is a genetic disease. It is almost exclusively in African Americans. 1 in 500 will have sickle cell disease. This is a genetic disease that results in chronic anemia, pain, disability, organ damage, increased risk for infection, and death. Okay, it's a genetic problem that results in chronic anemia, pain, disability, organ damage, increased infection risk, and early death. Really, when we say it's genetic, it's carried on that recessive gene. So in order for you to have the sickle cell trait or the sickle cell issue, both of your parents have to have the sickle cell gene in order for you to actually have the disease. There is some newborn screening that can be done. It's a certain type of hemoglobin. Now, I'm not getting into genetics, let me tell you. Unless you work it in genetics, hemoglobin S is the type of hemoglobin they're looking for, and that by doing that screening, it can identify an infant that has the sickle cell trait, sickle cell disease. That way, why would I want to know that? Why would I want to know that? Early education, parents know what to look for. Okay, this is a lifelong chronic issue with flare-ups, and you have those problems that we talked about: pain and disability and organ damage and early death. Okay, so what happens, the patho for this is that the red blood cells that are usually donut-looking, right, they become sickle-shaped. And so as sickle-shaped is like this, like a bowl, kind of. I'll show you a picture in a minute. But what happens is they become very sticky and they stick together, and you get very abnormal chains and clumps of these sickle cells, and they actually block off blood flow. Okay? Now, the sickle cell trait, if your patient has that trait, they have mild manifestations of the disease, but they can still pass it to their children. Okay, so because we've got these weird sickle-shaped cells, the hemoglobin chains that are in those cells, are very abnormal, and that cuts down on the oxygen that red blood cell is able to carry. So not only are they clumping, but they're not carrying the amount of oxygen that a normal red blood cell is able to carry. Now, what we have to be aware of, and what we usually are taking care of, is when a patient gets into a sickle cell crisis. This is a periodic episode of extensive cellular sickling. These cells become stuck together, and they get stuck in the larger blood vessels, obstructing blood flow. It is very painful, and your patient has hypoxia. And remember, this is periodic, so it recurs from time to time. And the more events they have, the more organ damage that occurs because of the anoxia and the tissue actually infarcting. Okay. Most of the time, your patients who have sickle cell live their lives and they do fine, and we only see them when they have a crisis episode. Okay? These are the folks that you see over and over and over, and you pretty much become on first name basis with them because you know they're going to be back. They come back. Okay. So this is a picture of what your normal blood cells usually look like. And this is a picture of those sickling cells. See how these are just kind of all misshapen? Okay, those just cannot carry oxygen like these can. Now we need to be aware that various stressors can actually trigger a patient to have a sickle cell crisis. And this is some of them here. Just becoming dehydrated. Infection, overexertion, cold weather changes, excessive alcohol consumption, and smoking. What do you notice about those items right there? What is it affecting? It affects your vasodilation and constriction, right? So that can throw them off into those into a crisis. Now your symptoms will vary. And it depends on where the blockage is, what organs are being affected. Okay? So circulation to the chest, abdomen, bones, joints, bone marrow, brain, or the penis may be compromised. Just depend on where the blockage is. But again, tissue hypoxia is what's going to be the result. And this is very painful for your patient. That is your most common symptoms. It doesn't matter where it is, it's painful. Okay. So, if it is in the cardiovascular, the changes that we see is we see decreased pulses. The extremities may be cool if it's in the in the legs. You may see an increased heart rate because the body's trying to compensate. Remember, trying to get more blood out there to that area that's blocked off. Your patient, your patient may develop some heart failure because of this overworking of the cardiac system. Your patient usually is pale. They may be cyanotic. Your patient may actually have jaundice because the body's trying to get rid of these weird cells and they're breaking those down. Your patient may have open sores on their leg. That's just from the peripheral vascular consequences. And it's from that poor tissue perfusion. Patients may get into liver damage, spleen damage. They may develop kidney failure from the decreased perfusion. Remember, your circulation to the brain may be compromised. So what do you think you'll see there? Confusion, maybe some lethargy, alterations in their level of consciousness, maybe some behavioral changes, seizures, and then your male patients may also have priapism as a result of the sickling. And you know what that is? That is a prolonged erection. Very painful. And your patient that has priapism usually cannot void. If they're distended, yes. Yeah. Yeah. You try to treat, that would be now if they're distended. Okay. They're uncomfortable from other things. They're not that uncomfortable from the bladder being distended yet. Okay. But if you palpate their abdomen and they've got like a basketball right here, yeah, they need to be capped. But in that case, the patient with a priapism, you have to take care of that soon. Because what's happening? The blood is there, but it's not leaving, right? It's not leaving, so what happens is the tissue gets compressed and starts to die. So fix that. That's got to be fixed. Okay? So, now remember, your patient is still anemic, right? Issues with red blood cells. So what else are you seeing? Shortness of breath. Okay, your heart rate's up a little bit. They're fatigued. They're weak. Still got those signs and symptoms going on. But this is not this is not an issue with their iron. This is an issue with their cells and their cells clumping together. So, to make the diagnosis of sickle cell disease, they're looking at all this lab work. They're doing tests on the blood itself. They're looking at the percentage of sickle cells that they see on the slides. Okay. And then they're doing x-rays of those areas to evaluate to see if there's any bleeding, those type of things. But medical treatment for a sickle cell crisis, remember, there's no cure for it. We have to treat the symptoms. In your book, on page 875, is a chart that talks about how to prevent a sickle cell crisis. And on 874 is how to take care of a crisis. That's chart 42.2. 42.2 and 42.3. Look at those. Okay. Usually if your patients have a crisis, a mild crisis, they can handle that at home. Pain control is their goal. Okay, so they may be taking opioids at home. And that's what we tell them, to take their pain medicine, increase their fluids. We want to try to dilute as much as we can. Okay. But in the hospital, we're doing very aggressive IV hydration, about 200 milliliters an hour for the first hour or so. You may even give your patient a bolus, where you just run in about 400 or 500 milliliters at one whack. Again, this is not your call. This will be ordered for you. So we're doing that to prevent dehydration, and it helps the kidneys to clear the waste from those ruptured red blood cells. In the hospital, we're giving IV pain medications, morphine, Dilaudid, at least for the first 48 hours. Your patients may even be given a PCA pump to give themselves those medications. That works great. That works wonderfully. If it's not PCA, usually their medications are ordered scheduled. It's not PRN. You're giving them around the clock to your patient. IV fluids, we're giving the hypotonic. Why? What does it do? Huh? It blows up the cells. It certainly does. It expands the cells and hydrates the cells. Good. Right. Okay, so hypotonic is the choice there. We may need to give our patients red blood cell transfusions, to kind of help with the anemia. Give them some red blood cells to help with the hypoxia. And then hydroxyurea is a medication that you may be asked to give that stimulates the production of a type of hemoglobin that is very resistant to that sickling of the cells. But it's got a lot of risks associated with it, so it's not for everybody. Your patient has to be put on oxygen. Pain control, IV fluids, got to hydrate them, oxygen, and then we may be giving them some blood transfusions. But basically, again, we're managing the symptoms. Managing the symptoms. Assessment of our patient. We've got to get a good description of the pain. Okay. You'll hear people come into the hospital and they're concerned with people getting addicted and all that business. Pain control is really important. It really only 2 to 5%, I think Iggy says, of your patients will actually develop a problem with opioid use or drug use, okay, because of their sickle cell. So don't withhold that medication. You're documenting all you can about their pain, what started it, what has helped in the past. We do want to do check their vital signs. Fever, looking for problems with infection, and monitoring for signs and symptoms of dehydration. We've got to keep these people hydrated. Remember, dehydration can throw them into a crisis. So, got to keep them hydrated. So, as a nurse, what do you think some of the nursing diagnoses are that you have for a patient that has sickle cell anemia? Pain, risk for impaired tissue perfusion. What else? Risk for infection. Risk for fluid volume deficit. What else? Risk for organ damage. Is that a nursing diagnosis? I'm just asking. I'll buy that, Scott. I'll buy that, honey. What about risk for injury? Why? Because we're snockering them. Hopefully, we can get them comfortable, right? Could be risk for impaired oxygen delivery. Maybe that's not NANDA, but I know what you mean. Okay, something in there like that, yeah. Okay, altered tissue perfusion, altered gas exchange, those kind of things. You think these people have issues with anxiety? You betcha, they sure do. How would you like to live your life knowing that at any moment you could be brought to your knees with a disease and it's going to keep happening? or that you could die early from this. Yes. So they have risk for injury. They also have risk for an ineffective therapeutic regimen management. That's why when a patient is diagnosed with sickle cell, a lot of education is needed. They need to know what stressors can cause them to have a crisis, how to avoid it. A lot of times these folks can't work. Okay. Look at this hand. You think this hand's got some issues with some perfusion? So good education, follow-up, and monitoring for these folks. Very important, very important. And again, you get to know these folks real well. You know, you know them, you know what they're back for, and, you know, first name basis. Okay. Questions about that? All right, a couple more and we'll be through. Let's talk about disorders of the hematologic system that have to do with coagulation problems. And when I'm talking coagulation, I'm talking about what? Platelets. I'm talking about platelets and clotting factors. Oh, no. Do what? Your hands are hurting? All right. Thrombocytopenia. Remember, penia means too few. So we have too few platelets that are circulating in the blood. So either there's not enough platelets that are being made in the bone marrow, or there's too many are being destroyed once they get out into circulation. Okay, and I'm not concerned that you tell me whether it's ITP or TTP. Just know that you've got too few platelets. This is usually a result from chemotherapy or radiation. Right. Okay. Chemotherapy and radiation do not distinguish between good cells and bad cells. Okay, rapidly dividing cells. Okay, they're just looking for rapidly dividing cells. Okay. And rapidly dividing normal cells are cells that, those are the ones that produce platelets. So what we see in these folks, we see bleeding issues. They have petechiae and purpura, little purple dots or big purple splotches. They may have bleeding from their gums. They have nosebleeds and unusual or prolonged bleeding. And what we do is we try to identify and treat the cause. When you're going to see this stuff again, guys, when y'all start talking about oncology and radiation and chemo, so you'll see this again. But let's say that you have a person who has a very low platelet count. What is your goal in this person? To decrease what? To increase what? That's not your goal. What is your goal for your patient? That's your nurse's goal, but what's your patient's? Your goal for your patient, yes, is to keep from bleeding by preventing injury. You want to prevent bleeding in this patient. You're not raising the platelets, you're preventing injury and preventing bleeding. So these folks require very gentle handling. We use a lift sheet under them to lift them and move them. We don't drag them up the sheets. Okay? We don't grab them up under the arms and move them up to the head of the bed. We don't do that. We're gentle with these folks. Because remember, they don't have enough platelets. You get a bruise, it's not a little bruise, it's a big bruise. Okay? We want to make sure that we're not doing IM injections or venipunctures unless we just absolutely have to. And when we do, we have to hold pressure for a lot longer than we usually do. Soft toothbrush. No flossing. We want to avoid any kind of rectal trauma. Okay? So no rectal temps in these folks. No enemas. No suppositories. None of that fun stuff. Okay? And we have to constantly be watching for spontaneous bleeding. Okay? So thrombocytopenia, difficulty in stopping bleeding. Be easy with these people. You may see a condition called disseminated intravascular coagulation, or DIC. Everything's messed up. This is where you have overstimulation of the clotting cascade, and the body's trying to compensate. So you have two things fighting against each other. So you've got excessive clotting, and as opposed to excessive hemorrhaging at the same time. Everything is messed up. This is always secondary to another pathologic process. This is a bad thing to have right here. You got clotting all over your body, and then you have hemorrhaging all over your body. So we want to fix this. It may be as a result of overwhelming sepsis, major trauma, crush injuries, burns, cancer, or it may be from obstetric complications. The worst case I ever saw was on a patient who had she was pregnant, didn't know she was pregnant, and the baby, she was obviously pregnant if you looked at her, but she said she didn't know she was pregnant, and the baby was dead. So no telling how long the baby had been dead. So she was getting into DIC because of the sepsis and the huge infectious process that she had going on in utero. She about died. She was about there when she got to the hospital, but that was what hers was from that overwhelming sepsis. Worst case I've ever seen. But coagulation occurs at so many sites that eventually all your platelets are used up and your clotting factors are depleted, so that's when the hemorrhage starts to happen. That's basically what happens. So with DIC, we're going to diagnose that with our labs, our patient presentation. Okay. These folks are sick. These folks are critical. They've got to have blood replacement therapy. Not only blood, but they've also got to have plasma, clotting factors replaced. And these folks are usually given heparin to stop that clotting cycle there. And it allows the body to replenish the platelets in the clotting cycle. So heparin may be what we give first, but then we're going to, replenish some of that with the blood components. Some of your physicians actually feel that by giving blood products, that actually adds to that abnormal pathophysiology there, so they may hold off on giving the blood until they just absolutely have to. They may just try to treat the symptoms and, give them the heparin. And you're taking care of DIC in the intensive care unit. DIC, ICU. And we're not handling, these people aren't staying out on your floors, med-surg floors. One more. Hemophilia. Hemophilia is a genetic disease where your affected person lacks some type of clotting factor that you normally see in the plasma. You have different types of hemophilia. A is lacking a certain clotting factor, which is clotting factor 8. And hemophilia B is missing clotting factor 9, if you're just so prone to know that information. Okay. But what you have is, you have uncontrollable bleeding with very minimal types of trauma, or very minimal, they just bleed. Okay? It can occur after trauma, but it also can just occur spontaneously. For no reason, no trauma, no nothing. This is usually a male disease. You don't usually see hemophilia in women. And usually your bleeding will occur in the joints. So they have painful joints, a lot of swelling there. Mobility is an issue, but it can also happen from anywhere. Bleeding can happen from anywhere. Skin, mouth, gums, lips, and from the GI tract. You can also bleed into your head from hemophilia when your patient has a stroke. Any surgical or invasive procedure puts the hemophiliac at risk for bleeding. So you've got to make a really good pre-procedural assessment and evaluation before you do anything on these folks. Diagnosis is made by looking at clotting factor levels and also clotting, PTT times, bleeding times, those kind of things. Okay. But definitive diagnosis is going to be on the clotting factor absence. Again, there's no cure, but we're going to treat the symptoms. And when your patient is bleeding, we've got to replace those clotting factors, right? Because that's what they're missing. So we've got to give them fresh frozen plasma. We may be giving them cryoprecipitate, which is just specific factors, clotting factors, or both. If they've bled enough, we may need to replenish the whole packed cell, giving them red blood cells. These patients usually need pain medication. We start them off with IV morphine, but we quickly try to get them off the IV fluids, the IV pain meds, and get them to the oral meds. Hopefully the non-opioids as soon as we can. Because again, this is a chronic condition. And they can have flare-ups from time to time, bleeding from time to time. And we're just writing. So with our assessment, what are we assessing? Breathing. Bleeding. Did I say somebody say bleeding? Yeah, let's assess the bleeding. Where is it? How long has it been going on? What have you done to stop it? What started it? Right. What has happened? What have you bled from this area before? Okay. What measures have stopped it and what has relieved the pain in the past? He's got a patient that's bleeding. Remember, you want to look at their vital signs. Are they getting hypovolemic? How do I know a patient is getting hypovolemic? Low blood pressure. What else? Increased heart rate and increased respirations, right? Okay. Got to monitor their urine output. Why am I concerned with that? Remember, if they're hypovolemic, kidneys are not being perfused, right? So their urine output will decrease. So we need to watch for that. Interventions are based on your patient's risk for injury, your patient's acute pain, and then again, any patient can have ineffective therapeutic regimen management. Okay. But again, manage the bleeding, put some pressure on it if you can. Okay. You could, but usually their blood pressure is just low anyway. If they've bled a good bit, your blood pressure will maintain for a while. It'll maintain for a while. But if you've got the high heart rate and the high respiratory rate, and then the low blood pressure too, then you've got some issues there. What happens to their extremities when they're hypovolemic? They're cold. They may be pale. Maybe blue. All that business, right? Good. All right. Any questions about any of that? Valerie, don't ask me what's on the test. I want to ask the question. It'll be 15 or below. 10 to 15 will be me. 10 to 15 will be my content. All right, so we will